Hi, it's Sierra Silas, and it's July 21st. So I'm going to be presenting my case connections for case number 4, and I'm going to be answering cases 1 and 4. So here I'm going to first talk about the removal of nitrogen from amino acids, and so this is done through transamination reactions and then oxidative deamination. So the amino acids will be converted down into their nitrogen molecule, which could then be excreted or reused, and then the containing carbon skeleton will be used for energy in the form of ATP. And then here we'll just look at the transamination reaction, so what takes place. So virtually all amino acids are going to undergo this process besides thyrine and lysine. They will go straight to oxidative deamination. And so in this step, the amino acid catalysm involves the transfer of the alpha amino group, which you could see on the side of the equation with the pink NH34, from the original amino acid to a carrier molecule alpha ketoglutarate, and the transfer of the amino groups on carrier molecules forming our products. So we'll form glutamate that you could see here, and this will then be used to undergo oxidative deamination. So then I'm just going to talk about the enzymes that catalyze this transamination reaction that we talked about. So the aminotransferase or transaminase enzymes. And so these enzymes, they catalyze this step and they're found specifically in the cytosol cells. So there's two that I want to discuss, the alanine aminotransferase and the aspartate aminotransferase. So alanine and ketoglutarate will be transferred with the alanine aminotransferase to pyruvate and glutamate. Pyruvate's the alpha keto acid, you could say. And then also in this step that they require the enzyme, the alanine aminotransferase requires vitamin B6 as a coenzyme, which is peroxidyl phosphate, and that's found in the alanine near the carrier molecule. And then the second one, which is a little less common, glutamate and oxaloacetate, and that'll be transferred to alpha ketorate and aspartate using the aspartate aminotransferase enzyme. And then now we're going to talk about, so from here we can go to oxidative deamination. So here glutamate will be transferred to alpha ketoglutarate and it'll give off ammonia. And the enzyme that'll catalyze this reaction will be glutamate dehydrogenase. And this enzyme is predominantly found in the liver and kidneys, and it's going to use NAD plus and NADP plus as coenzymes. So all amino acids, they are commonly converted back to glutamate because the cells have a quick way of converting it back to the alpha keto acid, which you can see here, and forming ammonia. So that's why this process is favored. And then we'll talk about ammonia transport. Sorry. Okay. Oh, there we go. Ammonia transport. So ammonia produced by peripheral tissues is toxic in the blood, and it needs to be reconverted before being transported to the liver. So that's this process here. So the ammonia is combined with glutamate to form glutamine, and the enzyme that catalyzes this reaction is glutamine synthase, and ATP is used in this reaction as well. So glutamine will be released from the blood and it travels back to the liver, and that's where this conversion will happen. And then the liver, the ammonia is also used to form urea. So I also want to address the second part of the question about the gluconeogenesis pathway, and in the fasted state, glycogen stores will be depleted, so to synthesize glucose we'll have to use alternative pathways. So we'll use lactate, glycerol, pyruvate, gluconic amino acids, and adjuvant fatty acids, and both the fatty acids have nitrogen in them, so that's how nitrogen is related to this pathway. And then here is showing the urea cycle. And so I found that there was most likely a deficiency in the ornithine transcarbamylase enzyme, which you could see in the corner over there. And this was indicated by the ammonia being elevated and by the uric acid levels being elevated. And you could see the reaction that it converts here. And these are all the other enzymes that were involved in like potentials for deficiencies. But in the case of the OTC deficiency, the arginine will now become an essential acid in order for protein metabolism to keep up and function properly for the cells and the body's needs. So that's all in the case 1. Then I'm going to move on to case 2 about the vitamins. It's case number 4, but my second case that I discussed. So I concluded that the patient most likely had a vitamin B12 deficiency. And so firstly, I was indicated by this because the physician initially diagnosed the patient with megaplastic anemia, and vitamin B12 and folate are responsible for that. So that's what concluded me to think that it was vitamin B12. And then other symptoms of vitamin B12 deficiency that were common in the patient was progressive fatigue that progressed over the 6 months, and the beefy red tongue, which I found in studies was very indicative of vitamin B12 deficiency. And also, she didn't report having any neurological or cardiac symptoms, but she did report having tingling in her lower legs when she was walking, and so that is indicative of neurological symptoms that are sometimes seen in patients with vitamin B12 deficiency. And then this image that I drew is just showing the absorption of vitamin B12 into the stomach, through the stomach to the aluminum. So it's also paired with an intrinsic factor, a glycoprotein, to be absorbed in the body, and then you could see how it will go to the blood and certain receptors of the body for vitamin B12. And then another important factor about vitamin B12 is that it's an important cofactor for methionine synthase and methylmalonyl-CoA mutase. And so methionine synthase is used for protein synthesis, and it also prevents homocysteine accumulation in the body. And then methylmalonyl-CoA mutase, it will use vitamin B12 in order to catalyze its conversion to succinyl-CoA. So these are 2 essential processes, and the vitamin B12 helps them with this, and that's why the deficiencies are important to address. So then I'm just going to address the other possible choices that there were. So the vitamin B6 deficiencies, common signs of this were seizures, lactic acidosis, dystonic movements, and plasma disorders. So there was certain plasma disorders seen in the patient, and the irregular movements that she was having with tingling and numbness and trouble walking, she was saying. And then iron deficiencies. So I also found in studies that most women that experience iron deficiencies, it's due to losing a lot of blood during their menstruation cycle. And so iron is carried in the hemoglobin of the blood and the red blood cells. And certain signs of this are pale conjunctiva and shortness of breath. So that was found in the patient. So that was why this was also a possible choice. But vitamin B12 deficiencies could also show pale conjunctiva, so there were some overlapping symptoms, which is why it would be essential to run further tests to help ensure that it's a vitamin B12 deficiency. So some tests that I think would need to be done would be blood tests to show if there's low serum levels of vitamin B12. So I found that in most studies, however, that this can't just be a final diagnosis because there's a lot of false positives or cases where people have low vitamin B12s, but they're not experiencing any serious conditions or illnesses. So it might not show up right away, and that might not be the key factor. So to keep going, you could look for elevated levels of methylmalonic acid and homocysteine, which will be indicative of the vitamin B12 deficiencies. And then also, this was less common just because it's a more invasive procedure, but bone marrow biopsies could be done and then analyzed, and it could help rule out diagnoses of myelodysplasia, and it also could be useful to assess the iron stores in the body. And then I just listed my references that I use here, and they're also in my script that I'll be submitting. If you guys have any questions, please let me know. Thank you.